and he will be giving us a talk on going back to old school, leveraging EGMs to improve efficacy and safety in ablation.
Good morning, everybody. It's a great pleasure to be here. And DJ, thank you for the invitation, and congratulations on another successful KCHRS. What I'd like to discuss today is going back to old school, really, going back to the basics of how to use our EGM in a more efficient way to hopefully improve our efficacy and safety of ablation. As you know, these are my disclosures. And as you know, we enjoy in EP nowadays a bunch of innovation, and really there has been a quantum leap in technical innovation from mapping perspective and ablation technology perspective. However, as you know, the successful of a mapping and ablation procedure continues to depend on critical acquisition of EGMs and handling them. So the EP lab is definitely a very noisy environment, from anything from your IV pump to the anesthesia equipment to even the headsets in the ablation that you use will create a lot of noise and reduce that signal to noise ratio. Hence, if we improve on the fidelity of our recordings, we can potentially improve the efficiency and safety. So in that respect, the pure EP system is really a breath of fresh air in this field. So in the next few minutes, I will discuss, number one, how the system accurately handles the signal information and preserves the physiologic signals without artifact. Then we'll share a few cases that we've done in the lab and how that improved our clinical workflow and efficiency. And finally, we'll glance into the new version of the system and some of the cool features that are coming up. So how is the pure EP different? Above you see how the conventional system acquires the very small information, very small EGMs, and essentially goes through multiple layers of filtering and gain until it transforms your analog signal to the digital signal that you're seeing on the screen. For the pure EP, what it does, it takes that same signal and subjects it to a very minimal preconditioning, and there's a fixed gain on that with really a dynamic range, and you have more of a digital filtering and processing. That will result in the following. If you compare pure EP to the conventional system, you do see much less harmonic ringing that you typically see with the conventional system, and you preserve more of the voltage, the EGM that is manifested. So as you see on the left side, there is usually 30 to 35% attenuation in the signal amplitude with the conventional system. Now, let's look at some real case examples. We'll start with something simple, a paroxysmal AFib coming to the lab for cryoablation. And there you see the Achieve catheter, and in the Achieve 4, 5, and 5, 6, very, very tiny signals that are manifesting. Definitely these are clear PV potentials. But you know, this will look even more challenging when you go into the branches of the pulmonary vein. On those same signal, 4, 5, and 5, 6, very tiny EGMs with the Achieve, you know, and the spacing of the electrodes, sometimes it's very difficult to see these EGM. Not as challenging when you put the digital zoom on pure EP. Now, I invite you to look on each of these cases into that HFA, the high frequency algorithm, which is an algorithm that will confirm what is real for you or what is not, because it is looking and confirming the near field EGM. This is a recent atrial flutter, and I'm showing the conventional system. We did essentially use the Octaray. This was the first case of Octaray. Patient had a previous 2015 AFib ablation and came back with recurrent atypical flutter. So after building this beautiful 10,000 point map and doing the entrainment mapping, we knew that we are around the right carina. This is where the leak is. However, when you look at the system, when you look at the ablation catheter, it's very difficult to see these signals. This is a previously ablated area, and I could swear there was something in diastole. So when we compared the same signal, same time on the pure EP, you see this beautiful mid-diastolic potential, almost continuous signal in mid-diastole on the ablation distal. That is also confirmed with the high-frequency algorithm and one ablation lesion, the flutter terminated without further inducibility. A little bit easier case, this is an AT. We had only 3 catheters. That guy had a PFO, so we went back and forth to the left atrium, mapped to the RSPV, and after doing a Waka line around the right pulmonary veins, we still had difficulty because there was some exit from the vein intermittently. So in these cases, you know, we see that very often. What do you do? There's a lot of options. You can pace from the ablation line, look at the unipolar, look at the omnipoles even. I like usually to walk the line typically with the ablation catheter and look at the EGM. And this is, again, conventional system. On the ablation distal, you see this signal, which you're not sure, is this partially ablated? Is this far field? Similarly, if you look on the, essentially, especially the HFA algorithm, very clear, very sharp EGM along the carina, and that was gone with the ablation. All right, switching gear a little bit, this is a PVC ablation. This is a cusp PVC from the left. We mapped that. The map looked great, but I was still hesitant to ablate because the earliest electrogram, although beautiful QS unipole, was still hesitant. It was between 12 and 15 milliseconds. But when you digitally zoom on this, you could see on the distal ablation that very tiny EGM, a pre-QRS pre-local electrogram that was 22 milliseconds pre. So again, what I like to describe that digital zoom, you can zoom in without losing your details. I compare this to using an LED TV, essentially. You zoom in without the pixelation that you see with the old TV generations. Last case here, this is a VT ablation. And what it demonstrates when you use the system, if you are on ablation, if you are post-cardioversion or high output pacing, typically you saturate your channels with the conventional system, and there's a little bit of a delay in restoring your EGMs. Not much in this situation. You see there is a little bit of a noise, quite a bit of it actually, of noise on the ablation distal during ablation. However, you could still see the HFA, and that will correlate with what is the real EGM that you are ablating on the ablation catheter distal. Last thing here, this is essentially the new version. There are some cool features that will be released. This will be coming up in the next month or two. As you see, the video is playing that automatic tachycardia characterization. So what you can do with this new version is to assign to 1 up to 3 catheters, actually, the tachycardia. And that will take that tachycardia and memorize the pattern, and you can set a threshold for reference of cycle length. So how helpful is that? If you see that the tachycardia is wobbling above your threshold, more than 20 or whatever you set, it's going to change color. And that color change you see in the bottom on the CS, which was designated, it goes from orange to red here, and that will give you the automatic signal, the visual signals to stop collecting point or essentially reevaluate your entrainment map. So in conclusion, improving the fidelity of signal acquisition has definitely helped us in the lab to improve efficiency of our ablations. The HFA in particular, as I showed in our examples, have been very valuable in confirming whether what you're looking at is a real signal, is it a near field or not really. And by preserving the physiologic signal, we carry the potential of improving safety and efficacy of our ablation procedure, mostly by reducing how much ablation you give for each patient. And thank you so much for your attention.